Good morning, everyone. Today we will be covering breast carcinomas. Breast carcinoma is the most common malignancy of women globally, including the non-melanoma skin cancer. It causes the majority of cancer deaths in women. The incidence worldwide and the mortality are increasing at an alarming rate. The major factors underlying this trend in developing countries are thought to be the social changes, which increases the risk for breast cancer, like delayed childbearing, fewer pregnancies, and reduced breastfeeding. Combined to that, the lack of the access to the optimal health care. This figure highlights the 10 leading cancer types in terms of incidence and mortality in the United States in 2012, which is topped by breast cancer in terms of cancer incidence in women, and it's considered the leading cause of mortality in women after the lung cancer. A large number of risk factors for breast cancer have been identified. We will discuss some of the more important risk factors. Let's start with age. Breast cancer is rare in women younger than the age of 25, but increases in incidence rapidly after the age of 30. So about 75% of women with breast cancer are older than the age of 50, and only 5% are younger than the age of 40. Gender. The incidence in men is only about 1% of that in women. Family history of breast cancer. The greatest risk is for individuals with multiple affected first-degree relatives with early onset breast cancer. Geographic factors. Significant differences in the incidence and mortality rates of breast cancer have been reported in different countries, as the risk is significantly higher in the America and the Europe if compared with Asia and Africa, for example. Another example, the incidence and mortality rates are 5 times higher in the United States if compared with Japan. Furthermore, some risk factors must be modifiable because of the migrants from low incidence to high incidence areas who tend to acquire the rates of their new home countries. Diet, reproductive patterns, and breastfeeding practices are thought to be involved. In line with this, breast cancer rates appear to be rising in parts of the world that are adopting the Western habits. Reproductive history. Early age of menarche, which is the first menstruation, nulliparity, which means that this lady never have completed pregnancy, absence of breastfeeding, and older age at first pregnancy are all associated with increased risk, probably because each will increase the exposure to the estrogen. Ionizing radiation. Radiation to the chest increases the risk of the breast cancer, especially if the exposure occurs while the breast is still developing. For example, breast cancer develops in 25 to 30% of women who underwent irradiation for Hodgkin lymphoma in their teens and 20s, but the risk for women treated later in life is not elevated. Other risk factors include postmenopausal obesity, postmenopausal hormone replacement, mammographic densities, alcohol consumption. Regarding the pathogenesis of breast cancer, factors that contribute directly to the development of breast cancer can be grouped into genetic factors, hormonal factors, and environmental factors. Here are some examples of the genetic factors: BRCA1 and BRCA2. BRCA1 and BRCA2 are classic tumor suppressor genes. In that cancer arises only when both alleles are inactivated or defective. So BRCA1 and BRCA2 encodes proteins that are required for the repair of certain kinds of DNA damage, and they are normally expressed in many different cells and tissues. HER2 amplification. Cancers with overexpression of HER2 are highly proliferative. Hormonal factors. Estrogen stimulates the production of growth factors which promotes the tumor development. Environmental factors. Environmental influences are suggested by the variable incidence of breast cancer in genetically homogeneous groups. Like if we compare breast cancer incidence between two Japanese women, one living in Japan and the other is living in the United States, the incidence will be different because each lady had been exposed to different environmental factors. And this is also can be applied to the geographic differences in breast cancers that we mentioned before. The most common location of tumors within the breast is the upper outer quadrant, accounting for 50%, followed by the central portion accounting for 20%, and the upper inner, lower outer, and the inner quadrants each accounting for 10%. About 4% of women with breast cancer have bilateral primary tumors or sequential lesions in the same breast. Breast carcinomas are classified into two main groups. The first one are the non-invasive or carcinoma in situ, which we discussed in the previous lecture. The second group is the invasive or infiltrating carcinoma. So non-invasive carcinomas are characterized by being confined by a basement membrane, absence of invasion into the stroma, and the absence of lymphovascular invasion. This group includes ductal carcinoma in situ and lobular carcinoma in situ. The invasive or infiltrating carcinomas are further classified into the following groups. Invasive ductal carcinoma accounting for 70 to 80% of cases. Invasive lobular carcinoma accounting for 10 to 15% of cases. Carcinoma with medullary features, mucinous carcinoma, tubular carcinoma, each accounting for 5% of cases, and other types. This figure shows the gross appearance of the invasive breast carcinoma with felt gritty cut surface. As you can see, there is an irregular mass with very firm center, infiltrating into the surrounding breast tissue and adipose tissue. Such tumors are very firm and immobile on physical examination. As discussed in the previous lecture, the non-invasive or in situ carcinomas have two morphologic types: ductal carcinoma in situ, or DCIS, and lobular carcinoma in situ, or LCIS. So the terms ductal and lobular are misleading because both types of carcinoma in situ can involve duct or lobules. This can be explained as the following. Lobular carcinoma in situ usually expands the involved lobules without architectural distortion, and that's why it's called lobular, whereas the ductal carcinoma in situ distorts the lobules into duct-like spaces, and that's why it's called ductal. By definition, both respect the basement membrane and do not invade into the stroma or the lymphovascular channels. The most common type of invasive or infiltrating carcinoma is invasive ductal carcinoma, accounting for 70 to 80% of cases. DCIS is considered the precancerous lesion. Clinically, it presents as a mammographic density. It's a hard, palpable, irregular mass. Advanced cancer may cause retraction of the nipple or fixation to the chest wall. Invasive lobular carcinomas accounts for 10 to 15% of all breast carcinomas. In two-thirds of cases, those lesions are associated with lobular carcinoma in situ. In 10 to 20% of cases, the tumor may be multicentric and bilateral. Clinically, most cases present with palpable masses or mammographic densities. Histologically, the cells invade the stroma individually and often aligned in a single file. Carcinoma with medullary features accounts for 5% of breast carcinomas. Microscopically, they show characteristic large anaplastic cells with bushing, well-circumscribed borders and significant lymphocytic infiltrate. Precancerous lesions are usually absent, and they show increased frequency in women with BRCA1 mutation. This figure shows some of the histologic features of carcinoma with medullary features. The tumor consists of a tightly adhesive clusters of large anaplastic cells with bushing, well-circumscribed borders, and there is intense lymphocytic infiltrate at the periphery. Colloid mucinous carcinomas. This is considered a rare subtype. Grossly, those tumors are mostly soft and gelatinous. Under the microscope, the tumor cells produce abundant quantities of extracellular mucin that dissects into the surrounding stroma. As you can appreciate, there is abundant bluish mucin. The carcinoma cells appear to be floating in that mucin. The mucinous matrix gives the tumor the grossly soft blue to gray appearance. Tubular carcinomas account for 10% of invasive carcinomas smaller than 1 cm found with mammographic screening. It's almost always detected on mammography as a small irregular mass. Microscopically, this tumor is made of well-formed tubules with low-grade nuclei. Lymph node metastases are rare and the prognosis is excellent. This figure shows the histology of a tubular carcinoma. Here there is a well-differentiated neoplastic cells forming ductules that are widely spaced in a fibrous stroma. The following features are common to all types of invasive breast cancer. First, fixation, which means the adherence to the pectoral muscles or deep fascia of the chest wall. Retraction or dimpling of the skin or the nipple. This happens due to the adherence to the overlying skin. Bud orange or the orange peel. This happens due to the involvement of the lymphatic pathways, and this will cause localized lymphedema. The skin becomes thickened around the exaggerated hair follicles. Breast carcinoma can spread through lymphatics and hematogenous channels. The favored sites for metastasis are the bone, lungs, skeleton, liver, and adrenals. Less commonly, the brain, spleen, and pituitary. Metastasis may appear many years after the therapeutic control of the primary lesion. That's why we always screen our patients using MRI and the mammographic screening. The prognosis of a breast carcinoma or the clinical outcome for women with breast cancer can be predicted based on the molecular and morphologic features of the cancer and its stage at the time of diagnosis. Factors that influence the outcome include the following: the size of the primary tumor, the lymph node metastasis. Since the majority of cancers first metastasize to the regional lymph nodes, and nodal involvement is a very strong prognostic factor. Distant metastases. Distant metastases are only detected in 5% of newly diagnosed women. Histologic grade, including the proliferative rate. The histologic type of carcinoma. The presence or absence of estrogen or progesterone receptors, which predicts the response to the estrogen therapy. The proliferative rate of the cancer. This is evaluated by the mitotic count and is related to the responsiveness to the cytotoxic chemotherapy because rapidly growing cancer cells are more sensitive to agents that damage the DNA or interfere with the cell division. Aneuploidy, which has the worst outcome and means abnormal number of chromosomes. Overexpression of HER2. The importance of evaluating of HER2 is the prediction of the response to the monoclonal antibody used in the treatment for breast cancer, which is called Herceptin.